Alhamdulillah wa salat ala rasulillah. Assalamu alaikum wa rahmatullah. My name is Dr. Amber Khan, and I am the chair of IMANA Education Committee. Tonight, we will be hosting our first webinar. The Education Committee, our goal is to educate and promote health and wellness issues to our members and to local and national communities. And for tonight's webinar, we will have Dr. Marriyam Moten, who will be discussing hypertension in the clinical setting. Dr. Moten is a staff cardiologist at the VA Loma Linda Healthcare System out in California. And tonight she will be talking to us about a very common disease on hypertension. And while it is very common, it's something in which it's important for us to have a good refresher on hypertension and on this disorder, not just for ourselves as physicians, but also for us who may be patients of this disease. So Dr. Moten, when you are ready, we will be pleased to have you go ahead and get started.
Thank you so much, Amber. Thank you, everybody, for joining at this webinar. The purpose of this talk is not to make you a specialist in something, but just to give an overview of what hypertension, as we all see in our clinical setting day to day. You know, it's something as one physician would see and how they would refer to in a patient with hypertension. As you know, I am a life member of IMANA, and I have been participating with IMANA for quite some time. This is the first webinar that we're having with the IMANA at this time, and I hope all of you would love to enjoy it and listen to it in the near future as well. The objectives of the talk are presented here. Basically, what we want to do is increase awareness of essential hypertension, or high blood pressure, as it is called in layman's term. We will also highlight some of the importance of lifestyle modification. As you know, lifestyle modification is important for almost everything, whether you look for anybody with obesity, if you're looking for somebody who's a smoker, somebody who's got hypertension, or any kind of chronic illnesses, including diabetes. I do not have any conflict of interest as shown here. We will also talk about doing things that would assist our patient with the antihypertensive regimen. Sometimes the antihypertensive regimen can be complex. Sometimes, you know, you have people on multiple drugs, they don't know what time to take it, and with what can they take these medication. We will also update ourselves on the knowledge of new hypertension guidelines. And as you know, Ramadan is coming. We'll try and see if we can make it easier for most of our patients to take medications at the time that's more appropriate as they're fasting. Shown here is just a slide that I took off just from the Google. It's showing us how blood pressure should be taken and how we call somebody as hypertensive, yes or no. More often than not, we try to measure the blood pressure in the arm. And it's very important that when you listen to patients with blood pressure, you listen in a quiet room if you can, or you use an automatic blood pressure cuff medication. The blood pressure cuff should be placed in the upper arm in a snug manner as it is shown, and the stethoscope should be placed right on the brachial artery. Blood pressure, as you can tell, is the maintenance of the arterial blood flow, which is necessary for organ perfusion. We make sure that your blood pressure is not too high that can cause damage to the organs, or it's not too low so that the patient is not hypotensive or starts feeling dizzy, lightheaded, or having near syncope. Cardiac output and systemic vascular resistance are the ones that make up the blood pressure. Say, for example, if you get tachycardic, your cardiac output goes up because, you know, it's a combination of stroke volume and the heart rate. And if you're uptight for one reason or the other, if the patient is cramped for one reason or the other, then the systemic vascular resistance will go up, and so will the blood pressure. So we always try our patients, tell them always learn to relax. So when they're relaxed, the systemic vascular resistance is lower, their heart rate is lower, and therefore the blood pressure stays in a range that is supporting their organ perfusion, which are important. We call it somebody to have hypertension when the systolic blood pressure is greater than 130 or the diastolic blood pressure is greater than 80. The question always comes, when do you start screening people for hypertension? When they have any unusual symptoms, we do it. But generally, screening is recommended for everyone who's greater than 18 years of age. It is important that when they see their primary care provider or go to any kind of health fair, to just be screened for elevated blood pressure, because, you know, the sooner we find it, the sooner we treat it, the better it is. Hypertension, as you all know, is an important and is a preventable asymptomatic disease. That means the person will not have any symptoms. They will not feel anything unusual, and therefore, most people will tend to overlook it. So if you have somebody whose blood pressure is a little high, you can start modifying their risk factors for hypertension and control it without giving them any medication. Because if you leave hypertension uncontrolled, it will lead to multiple acute conditions, which can be life-threatening. For example, somebody could have a heart attack or a stroke, or if not, then they can lead to some kind of chronic illnesses, for example, kidney disease. And more often than not, I find a lot of people with heart failure and the blood pressure is high. The blood pressure was left uncontrolled, and that has led to them having heart failure. By heart failure, we mean that the heart muscles have gone weaker over time because the heart was not able to deal with high blood pressure for a long time, and then finally it decided to give up. And eventually it can lead to death, whether it's in the form of heart attack, whether it's in the form of stroke, whether it's in the form of any kind of chronic illnesses like kidney disease or heart failure. The worst part is there are at least 1/3 of Americans that do not know that they have hypertension. They are unaware of its presence, and since they are unaware, they don't know that they need treatment for it. Of course, the numbers have changed over the years, and now we think more than 1/3, more like half the people do not know that they have high blood pressure. As I've mentioned, hypertension is generally asymptomatic, but when it is left uncontrolled, that's when most of us wake up because it leads to chronic condition. And when it leads to chronic condition, it can be something that may be harder to treat. Those organs that are affected will no longer get back to their normal condition or normal way of functioning. When it is symptomatic hypertension, that's when we worry and we see them. That's when there is acute organ injury, and then there's full recovery of that organ is in jeopardy. Means, for example, somebody who's developed a hypertension which is severe, now they have a problem with their kidneys, they've gone into end-stage renal disease, they have had a myocardial infarction, a lot of things. Because of these acute and long-term sequelae of hypertension, it has received a lot of national attention and as well as global attention. As I mentioned, hypertension has rare symptoms, and we always identify through screening and when somebody is seeking healthcare for an unrelated problem. Some may have some kind of symptoms. For example, they may have headaches. Usually you see it when the blood pressure suddenly shoots up in somebody who has been, not taking good care of themselves. They may come to you with lightheadedness. Some may have vertigo, some kind of tinnitus. Tinnitus means buzzing or hissing in the ear. They may have some altered vision because their fundi are being affected, or they may have fainting episodes. On the physical examination, usually the first thing that we see is changes in the fundi. The optic cup margins are now getting blurred, and they have hemorrhages, or they have silver lining in their retinal arteries. It is all related to the duration of hypertension that they may have. In order to say somebody is hypertensive, we have got to make sure that we measure the blood pressure properly. The patient must be properly prepared. 9 out of 10 chances are if you go to a doctor's office, they will take the blood pressure when you're still in a hurry, you haven't had a chance to undress yourself properly and sit down in the chair. So it's important that the patient should be well rested. They should be resting in the chair for at least 5 minutes, and that their arms are at the level of the heart when you're putting the blood pressure cuff. And patients should not really have a full bladder, should not be too excited. We have got to make sure that you take proper measurements, hear the sounds properly, make sure you hear the cuff sounds, or you have the automatic blood pressure cuff on, and make sure that the readings are appropriate. If for any reason a patient's blood pressure is high, it's important that you take it more than once. Wait for a little while before you call them hypertensive. It's important that the blood pressure reading should be taken more than once, and properly document the blood pressure reading. It is important to average the reading. If you took one reading, wait for 5 minutes, take a second reading, and provide the blood pressure reading to the patient. Blood pressure is classified to be normal when the systolic blood pressure is less than 120, and the diastolic blood pressure or the lower sound of the blood pressure is less than 80 millimeters of mercury. It is known as being elevated when the blood pressure is between 120 to 129 and the diastolic blood pressure is less than 80. The moment the diastolic blood pressure goes greater than 80, that means the person is in stage 1 hypertension. Same thing about the systolic blood pressure. If the blood pressure systolic goes higher than 130, they're in the stage 1 of hypertension. And if it's greater than 140, then it's stage 2 hypertension. The important reason why you want to differentiate between stage 1 and stage 2 is to decide if you want to treat somebody with one medication or two medication. Of course, if the person has systolic blood pressure which is high as well as a diastolic pressure which is high, and if it's in one is in one range and as the other one as the other range, then it's important that you take higher of the two reading. As I mentioned earlier, when we're looking at the blood pressure reading, at first we used to think anybody greater than 140 over 90 was hypertensive, and the one greater than 130 over 90 we could ignore it, but not anymore. If you look at patients with blood pressure 130 over 80, 46% of the people are known to be hypertensive, but if you look at 140 over 90, it's 32%. With the change in the category of blood pressure reading, as well as the new cutoff point as defined by JNC7, more patients are being now classified as being hypertensive. The reason was because when they found that you left somebody with a higher blood pressure, 130 or higher, the chances of them having an event, whether it's cardiovascular or neurological event, was relatively higher. So they moved on to the lower reading. With every increase in systolic blood pressure by 10 millimeters of mercury, it led to a person having an event, and therefore they have moved into a much lower levels of blood pressure. If you look at this chart, the blacks are the ones that are more likely to have hypertension compared to the other races. And the Asians are not too far behind. As you can see, we have 45% of us are documented to have self-reported blood pressure being elevated, or we are on antihypertensive medication. That means 1 out of 3 people that is on this webinar would have high blood pressure and may or may not really know it, that they are hypertensive or they're taking the antihypertensive medication. The cardiovascular risk factors goes along with the hypertension. It is not unusual to find people that are hypertensive. There are also smokers, whether they are having smoking on their own or they have secondhand smoking. Some of them can be also diabetic. Dyslipidemia and hypercholesterolemia also goes hand in hand with hypertension. Overweight and obesity have been the newer risk factors that are growing in leap and bounds as we are changing our diet and getting heavier over the years. And as we all grow older, we don't tend to have as a higher metabolism as we had when we were younger. Physical inactivity or low fitness is also associated with hypertension. So is the unhealthy diet. With the advent of all our remotes that we have become more inactive and tend to stay more inside the house than go outside and walk around or play games on the outside. There's some other relatively fixed risk factors that are associated with hypertension that includes chronic kidney disease, family history, increased age, and people with low socioeconomic status or having an educational status which is lower. They don't know the difference. They don't know how to read the labels, and they tend to take more of canned food, and with that, they seem to have more hypertension. As you saw in the previous slide, males tend to have more hypertension than women, and now there are 2 other risk factors that have come in, which were overlooked for quite some time. That includes the obstructive sleep apnea. If it's left untreated, that leads to hypertension, and also the psychosocial stress that we all know that causes hypertension as time goes along. The diagnosis of hypertension is made not just on the basis of blood pressure that is measured in the clinic, but it can also be made on the basis of ambulatory blood pressure monitoring. A 24-hour mean blood pressure of 125 over 75 millimeters of mercury or above is considered to be a diagnosis of hypertension. We expect that the daytime blood pressure to be 130 over 80 millimeters of mercury or higher in patients with hypertension. And when they go to sleep, as you can see, the blood pressure tends to be a little bit lower and therefore a mean of 110/65 or more is the one that can lead to diagnosis of hypertension if they have ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring is not covered by a lot of insurance companies, and we have to put an emphasis on as to why we need it, especially when we are looking for other conditions that may not necessarily be too obvious. For example, somebody having masked hypertension, or somebody that has stress-related hypertension or white coat hypertension. These are the corresponding values of systolic and diastolic pressures for when the blood pressure is taken in the clinic. Patients having home-based blood pressure monitoring or nighttime and 24-hour ambulatory blood pressure monitoring. By home-based blood pressure monitoring, we mean somebody who's checking the blood pressure once or twice a day and using a regular cuff, not necessarily an automatic one. Shown here, when you look at the clinic, if the blood pressure is 120/80, we expect their home blood pressure monitoring also to show 120/80, and same thing about the daytime ambulatory blood pressure monitoring. At nighttime, we expect them to be much lower. If we had an ambulatory blood pressure monitoring, which is 100/65, and if you look at the average for 24 ambulatory blood pressure monitoring, it can be a little bit higher, 115/75. In a person who is hypertensive, again, the blood pressure reading will also be corresponding, as noted here, but they tend to be a little bit higher with ambulatory blood pressure monitoring, and the average 24-hour ambulatory blood pressure monitoring is usually 125/75. In the patient that is in the hypertension category stage 1, you would expect the blood pressure to be 140/90, and with the nighttime ambulatory blood pressure monitoring, it would be in the normal range, but it is much higher than what you would expect in a person that would have a normal blood pressure. In normal blood pressure of 120/80 would reflect a nighttime ambulatory blood pressure monitoring of 100/65, whereas nighttime ambulatory blood pressure monitoring in a person with stage 1 blood pressure or hypertension would be 120/70. So, there is some correlation between the two. As I've mentioned earlier, there are certain terms that we look out for, and we want to make sure that the person doesn't have other conditions that may be overlooked. For example, somebody who has sustained hypertension, masked hypertension, or white coat hypertension. In a person who's normotensive, the blood pressure will be normal when they're seen in the clinic. And at the same time with the ambulatory blood pressure monitoring, or when they have a home blood pressure monitoring, no hypertension would be recorded. In a person who has got sustained hypertension, naturally their blood pressure would be high while they are seen in the clinic, as well as when they undergo ambulatory blood pressure monitoring or they do the home-based blood pressure monitoring. There's a lot of patients who cannot afford to have a blood pressure cuff at home. They can always go to a Walmart or somewhere else and get the blood pressure measured. Masked hypertension is when we do not see the blood pressure being high when they come to the clinic, but when they bring in the diary with the blood pressure, when they did the home-based blood pressure monitoring, the blood pressure would be higher, and it would be proven by the ambulatory blood pressure monitoring. White coat hypertension is when the blood pressure is high when they're seen in the clinic, but not necessarily when they bring in the logs for us to check. And generally, these are the ones, that tend to be a little bit hyper. They want to be sure that the blood pressure is high, yes or no, but when they bring in the log, the blood pressure is normal because they take it in much more calmer settings, and therefore the blood pressure is reported to be normal. Sometimes it's important when they come in with a normal blood pressure at home, but they're hypertensive in the clinic, to have their ambulatory blood pressure monitor checked and verified that it's recording these numbers right. And same thing about the home-based blood pressure monitor cuff that they may have at home to measure the blood pressure. It doesn't matter whether it's something that they wrap around their arm or whether they wrap around at the wrist to take the blood pressure. Irrespective of which one they use, all of them should be able to give an adequate reading, which should correlate with what the office-based reading is. So when we're looking for detection of white coat hypertension or masked hypertension in a patient, we always look at the office blood pressure, and if it's high, we have got to find out what the ambulatory blood pressure monitoring is, and if it's normal, that means that they have white coat hypertension. And if it's not, if it's high, then we worry about them and we have to tell them what to do next. Usually, those that have acute hypertension, we advise them to relax, exercise regularly, lose some weight, and change the diet as it may be necessary for them. And they need to come in annually to get their blood pressure checked, to get an ambulatory blood pressure monitor done for themselves. Those that are diagnosed to have a hypertension means that the ambulatory blood pressure monitoring, as well as the office blood pressure is high, then we have got to treat them as we think it's necessary for them. Those that have normal blood pressure in the clinic and we suspect masked hypertension on them, we look at the blood pressure recording at home. And if it's consistently on the high side, that means it's greater than 130/80, then we label them as masked hypertension. They have to continue with their lifestyle modification, as I mentioned earlier, and they need to be started on antihypertensive drug. Those that have elevated blood pressure and have normal blood pressure at home, you've got to make sure that they have the annual ambulatory blood pressure monitoring to be done to make sure it does not progress over the years. Those that are already on drugs, again, the same thing needs to be done. You've got to look at the readings, what they're bringing from home, as well as what we're getting in the clinic, and adjust the medication as it may be necessary in them. Hypertension in adults generally is of two types. One is the primary or essential hypertension, which forms the bulk of all hypertensive patients. That means 90 to 95% of people will have essential or primary hypertension. Very rarely we find secondary hypertension. Secondary hypertension is one that is due to some other causes, some other conditions, and generally getting them to work up for secondary hypertension doesn't turn out to be useful. We look for it when somebody has sudden onset of hypertension at a later age group or sudden spike in the blood pressure reading when they had been normal for a long period of time. Only then we look for secondary hypertension. For primary essential hypertension is generally related to their unspecific lifestyle and genetic factors, means that they have been not eating right, that they have been sitting more than walking around, not taking good care of their diet as well as their exercise on a regular basis. Genetic factors, we really can't do much about it. There are at least 35 genomes that are loci that are seen that can be related to essential hypertension. Lifestyle factors, as I mentioned, includes the excess salt that people take. We all like our fries and potato chips. We tend to be a little bit on the heavy side as time goes along. Some of us are smokers, and few people still use alcohol in excesses that leads to primary essential hypertension. 5 to 10% of cases, as I mentioned, are due to an identifiable cause, and if you can find it and if you can treat it, that may cure their hypertension. Those that have developed chronic kidney disease, their blood pressure is high, and generally treating the chronic kidney disease will lower it somewhat, but not necessarily get rid of blood pressure as a whole. However, if somebody has narrowing of the kidney arteries, one of the renal arteries, dilating that would help them with the blood pressure, but not necessarily take them off all the medication. Usually, these people that have renal artery stenosis are generally on, multiple drugs, about 3 to 4 drugs to control the blood pressure, and we may be able to cut down the drug to maybe 1 or 2 drugs. Some of them may have an endocrine disorder like Cushing's, and some may be using the birth control pill that may be causing them to have hypertension. These are some of the common causes of secondary hypertension with their clinical indications seen here. Most common are the patients with renal parenchymal diseases, people that may have renovascular disease, primary aldosteronism. Obstructive sleep apnea had been overlooked for a long period of time, but now we have found that patients with obstructive sleep apnea are prone to hypertension, and once they start using their CPAP, the blood pressure starts getting more towards the normal range. Have I been able to take anybody off the medication for hypertension after the obstructive sleep apnea is being treated? No, not necessarily, but we have been able to cut down the dose of the drug as well as the number of medication that they may be taking for their hypertension. Drug or alcohol use, we always worry about patients that are on methamphetamine and other recreational drugs that may have secondary hypertension, and having them come off those drugs helps bring the blood pressure more towards normal level. And steroids, as you know, also can cause secondary hypertension. There are some uncommon causes that includes pheochromocytoma, Cushing's disease, hypothyroidism, coarctation of the aorta, which may be either one that is diagnosed or it has been repaired already, but still they have their high blood pressure, primary hyperparathyroidism, congenital adrenal hyperplasia, mineralocorticoid excess syndrome other than the primary aldosteronism, and acromegaly. Treating some of these conditions can lower the blood pressure, and some of them can be cured. For example, a person with hypothyroidism, once you start giving them their synthroid, once the levels are in the normal level, the blood pressure tends to improve and can be taken off medication. Same thing about patients with hyperthyroidism. They're generally tachycardic, and because of that, the cardiac output is high. Once they're treated for the hyperthyroidism, the blood pressure goes more towards normal. And these are the ones that can be taken off antihypertensive medication. Patients with coarctation of the aorta, once it's repaired, the blood pressure does get better, but not necessarily towards normal level. And when the coarct reappears, the blood pressure goes up again. Moving on to essential hypertension, as I mentioned, there are gene and environmental factors. The non-modifiable factors are the 35 genetic loci that have been seen in a number of studies and have been identified, but there's still no cure for it. It's just something that we inherit over time, and that causes them to have high blood pressure. If the mother is hypertensive, father is hypertensive, the chances of the kid being hypertensive also increases. They have second generation that are hypertensive, uncles, aunts, or grandparents. Some of them may be spared from hypertension, but if both mother and father have hypertension, the kids also have hypertension. Some of us think it's because of the genetic, not just of the genetic factors that they are sharing in common with their parents, but also the diet that they're sharing with their parents, the exercise that they may or may not be doing. And, all of these play a role. Blood pressure does increase as we all grow older, so it's important that we look out for it. Make sure the blood pressure is checked over time, every few months. If you're not hypertensive, have it checked every few months, so that if there is any signs of hypertension, you can change your diet, change your lifestyle a little bit more, and take care of it without going on to medication. The best treatment is not to be on medication, but if you need it, of course you need to take it. Modifiable factors are the environmental factors, high salt intake in patients that are salt sensitive individuals, usually the African Americans. They tend to be more salt sensitive. They tend to retain more salt in the system and tend to be more hypertensive. As I've mentioned, lack of exercise, obesity, and depression can also be related to hypertension. Caffeine consumption is known to cause hypertension. Therefore, when we are taking patients' blood pressure, we ask them when was the last time that they had the coffee, and based on that, decide what the blood pressure reading would be. Vitamin D deficiency has been found to be related to hypertension and also to heart failure, but the relationship is not that clear. Insulin resistance is also related to hypertension. Both of them go hand in hand. There are some events in early life, for example, low birth weight, somebody who is born with a low birth weight, a mother has been smoking and had not had breastfeeding done for them, then those tend to get hypertensive as time goes along. An incidental finding also has been people that live in the Northeast tend to have higher blood pressure, and the blood pressure is higher, more so in wintertime, and it's assumed because they have more vasoconstriction, causing them to retain the heat and leads to high blood pressure. There's some testing that needs to be done whenever we're suspecting primary hypertension in our individual. The basic testing that we always try to do is our CBC and doing a CAM7 and getting the lipid profile, thyroid stimulating hormone, as well as the UA. EKG is also done in most primary care offices, and they look for LVH. Among the fasting blood sugar, we are looking for presence or absence of diabetes. The complete blood count, we're looking for presence or absence of anemia, or somebody having any other abnormalities in the blood count. In the lipid profile, we're mostly looking out for the triglycerides, LDL, and a low HDL. Usually the triglycerides are elevated based on the carbohydrate diet that they may be taking. Their LDL is elevated because of all the meat and protein that they may be taking, and HDL would be lower because they're not exercising as they should. HDL goes up with exercise, goes down with lack of exercise. Serum creatinine is important, and we also look at GFR. And if the GFR is low, we know that the patient has developed some kidney dysfunction, and we expect them to get hypertensive as time goes along. Serum sodium, potassium, and calcium are also important. The person that has low potassium tend to be more hypertensive. Sodium, similarly, if they are high or low, that affects the blood pressure. And if the calcium is low, that can also affect your blood pressure. Thyroid-stimulating hormone helps us differentiate between hypo and hyperthyroidism, which may be masked, especially the hypothyroidism in elderly person. As person grows older, most of the organ system starts producing less hormone, and thyroid, when it's less produced, the TSH goes up. And once you treat that, they have subclinical hypothyroidism, and once you treat that, the blood pressure would become normal. UA gives us a screening test showing if the patient has got albuminuria, yes or no, or any underlying asymptomatic bacteriuria may be present, and the person may have some kind of an infection. If you treat that, the blood pressure can also become normal over time. EKG usually shows the presence or absence of LVH. If the LVH is present, you know that the person has been hypertensive for a long period of time. Only 40% of LVH is picked up by electrocardiogram. Echocardiogram is the one that picks up more LVH than the electrocardiogram. Therefore, getting an EKG and looking at the normal voltage, not seeing the presence of LVH, need not necessarily rule out any LVH on a patient. So generally, we look for STT wave abnormality as well. That will show us if the electrolytes have been abnormal, if they have any strain over the heart. Those are indirect clues for us. The other optional testing that are done are the echocardiogram, uric acid, and urinary albumin to creatinine ratio. These are the best proven non-pharmacological intervention for prevention and treatment of hypertension. Weight loss, healthy diet, reduced intake of sodium, and intake of dietary potassium. So if you have somebody who is heavy and say, for example, somebody that weighs 100 kg and the blood pressure is 160, if you can talk them into losing at least 20 kgs of weight, not necessarily overnight, of course, over a period of time, you will notice that the blood pressure will return more towards normal. For every loss of 1 kilogram body weight, the blood pressure should fall by at least 1 millimeters of mercury. Some books will say 1 millimeters of mercury for 1 pound, but generally it has been proven that it's 1 millimeters of mercury for every kilogram reduction in body weight. So in a person that's hypertensive, you can expect easily to, if they have lost about 5 kg or 10 pounds of weight, usually about 11 pounds of weight, they would decrease the systolic blood pressure by at least 5 millimeters of mercury. Diastolic blood pressure doesn't get affected as easily, and the diastolic blood pressure may fall by 2 millimeters of mercury, not by 5, as it is with systolic blood pressure. Having a healthy diet, that's more important. And this is the diet that most of us as Muslims take, usually the diet that is rich in fruits, vegetables, whole grain, and low-fat dairy product with reduced content of saturated and total fat. We take a lot of fruits and vegetables. Fruits are usually taken along with the milk, which we generally assume that it's a low-fat dairy product that we're taking in the evening when we have our iftar. If not, then it's time for us to look into that for iftar. Same thing about vegetables. If you eat a whole lot of vegetables, that will bring your blood pressure down. Whole grains, we all enjoy it, and that's important. That also helps us lower the blood pressure. And as you can see, it brings down the blood pressure by at least 11 millimeters of mercury. So if you have somebody with a systolic blood pressure of 130, and if you can encourage them to take a healthy diet, the blood pressure will be normal, usually about 120 in in a few months' time. You need to wait only about 3 to 4 weeks if they start following a good diet to say that the blood pressure has improved. Dietary sodium, that's very important. More often than not, we're living off the canned food because, it's easier. By canned food, I mean our peas and corn and our tomato paste that comes in a can, our vegetables and other kinds of fruit that come in a can that we can easily open up a iftar and eat it. It's important that we should try and avoid that because that is one of the other reasons why the blood pressure would go up. If you prefer, you can take anything that's frozen, but not something that comes in a can. Anything that comes in a can has a lot of salt in it, even though it will say no salt. Dietary potassium is important. Taking dietary potassium is helping us with our blood pressure, and if we take a lot of khajur, that will help us bring down the blood pressure. Exercise is important. As you can see, the aerobic exercises, 90 to 150 minutes per week of exercise, will lower your blood pressure by 5 to 8 millimeters of mercury or 2 to 4 millimeters of mercury in a person that is normotensive. Same thing about dynamic resistance exercise in a person that does not like to walk. You can tell them move their arms a little more, do something, squeeze a ball, especially in a person that's relatively elderly, doesn't want to go outside. That will help them lower the blood pressure over time. If we also have our namaz, standing up, that is our aerobic exercises. And if we do our tarawih in a proper fashion, standing up, doing our sajda and all that, I'm sure that will be counted towards our exercise every day. And that will help us lower our food as long as we are relaxed. If we are relaxed, the blood pressure will come down. And if you can keep the blood pressure low for a period of time, the overall effect on the blood pressure will also decrease. Alcohol consumption, generally we recommend that people drink very little alcohol, and we as Muslims don't really drink alcohol, so it does not apply to us. If person that drinks more than 3 drinks per day are tend to be more hypertensive for male, and 2 drinks per day in women can lead to hypertension. There are some other terms that we need to be aware of. They are the hypertensive crisis, that includes hypertensive urgency and hypertensive emergency. We call it urgency when there is no evidence of end organ damage. Treatment is by giving them oral medication to lower blood pressure gradually over 24 to 48 hours. And hypertensive emergency is when there is evidence of direct damage to one or more organs. Most affected organs include the brain, kidney, heart, lung, and they all produce symptoms that are related to that particular organ. For example, if the brain is affected, the person will be confused, will feel drowsy. If the heart is affected, then they will have chest pain and breathlessness and things like that. So depending on what the condition, which organ is being affected, that's what we have to worry about. Hypertensive emergency is something that requires blood pressure to be reduced rapidly. And therefore, these are the ones that we have to give them IV medication to reduce the blood pressure. However, there is lack of randomized controlled trial to show that bringing down the blood fast will help them. We usually put them into the unit and give them IV medication or in telemetry and gradually lower down the blood pressure. Severely elevated blood pressure, as you can see on the top, includes people that have systolic blood pressure greater than 180 or diastolic blood pressure greater than 110. If they have just severely elevated blood pressure without any evidence of end organ damage, more often than not, we should be able to treat them in the clinic or as an outpatient. Those that you see any kind of direct damage to one or more organs, they need to be referred out to the emergency room. Give them some medication, send them to the emergency room, and let them be admitted to have the blood pressure brought down as soon as possible. Pregnancy is all different thing. 8 to 10% of pregnancies will be affected by hypertension. It has to be blood pressure greater than 140/90, and the blood pressure has to be taken at least 6 hours apart. Means you saw somebody today and the blood pressure was greater than 140/90. If the patient can wait for a few hours, fine, you can take another blood pressure reading. If not, then the very next day, if you see both of them, then it is known as hypertensive hypertension in pregnancy. These patients can have pre-existing hypertension, they can have gestational hypertension, or be preeclamptic. Preeclampsia involves 5% of the pregnancy and it's serious. It is usually seen in the second half of pregnancy and in the postpartum period and is associated with proteinuria. The reason we worry about it is because it leads to maternal death and at the same time it doubles the risk of death of baby at birth. Usually these people have no symptoms in preeclampsia and it's only detected by routine screening. Some may have symptoms. When they have these symptoms, that's when we start thinking about eclampsia. Usually they'll come in first with headaches, visual disturbances, often flashing lights because of the hemorrhages in the retina that they're having. Some may have vomiting, pain over the stomach. We worry about them losing the baby, and they may have swelling in the legs. When it progresses to eclampsia, it becomes life-threatening, and it will lead to pulmonary edema and DIC. On the other hand, gestational hypertension is a new onset hypertension which is seen only during pregnancy, but it is not associated with protein spilling in the urine. So gestational type hypertension also has to be treated, but it's not as aggressively, or we don't have to worry about it as much as preeclampsia and eclampsia. Returning back to the treatment of hypertension, pharmacological therapy has remained the same over the years. We usually prefer that most people be given thiazide diuretics, like hydrochlorothiazide, chlorthalidone, or calcium channel blocker. And if for any reason these two medications cannot be given for some other compelling indication that they may require some other medication, then you could move to beta blocker. But generally, you try to look for thiazide diuretics, calcium channel blocker, ACE inhibitors, or ARBs. And they're more important for people that are with diabetes, irrespective of race, and also for African American. Thiazide and calcium channel blockers are preferred for African Americans or blacks that do not have diabetes, but those that have diabetes, it's important to start adding ACE inhibitors or ARBs in these patients. Medication dose is titrated upward with one medication prior to adding a second medication, but if the blood pressure is greater than 20 millimeters of mercury from baseline for systolic or greater than 10 for diastolic, then you may have to start with two medications at the same time. In some cases, a third drug may be necessary. Shown here is the guideline comparison of goal blood pressure and initial drug therapy for adults with hypertension that has been put forward by a lot of different guideline committees in US, in Europe, and other countries, and all of them are looking at the same thing, indicating that thiazide type diuretics is the one that is preferred. Then you use ACE or ARBs or calcium channel blockers. And if for any reason you cannot give that, and if you go down the list as a whole, all of them are saying thiazide type diuretics, ACE inhibitors, ARBs, or calcium channel blockers. Then if for any reason you can't give that, or if the patient has any kind of compelling indication for beta blockers, then you give them beta blockers. Beforehand, we used to push beta blockers more, but now the pendulum has swung more in favor of giving them thiazide diuretics, ACE inhibitors, or calcium channel blockers. Here is a list of ACE inhibitors, ARBs, and other medication that can be given. And if you notice, most of them are just once or twice a day. So it cannot be difficult for most Muslims to take it and have the better control of the blood pressure. For example, if you give them captopril, you can start with 50 milligram BID, and the doses is 2 doses per day. You can give it to them 3 times a day if you like, but 2 times a day does the job good enough. Same thing about enalapril and lisinopril. Lisinopril, generally we prefer giving it once a day, but in some cases you may require it twice a day. And you can start with the low dose and then work your way up. Usually you start with 5 to 10 milligram of enalapril or lisinopril, and then increase it over time, depending on the blood pressure control, to 20 milligram of enalapril or 40 milligram of lisinopril. Some people may push it to 80 milligram of lisinopril, but after 40 milligram of lisinopril, the effect tends to kind of blunt out on the blood pressure. ARBs are important, and you can use any kind of ARBs for the patient. Losartan, valsartan is generally the preferred drugs for most of our patients that I see, but one can use one or the other. And generally, we have found, giving them once a day drug is more than enough. You remember not to give the ACE inhibitors and ARBs together. You can give either ACE or ARBs, and depending on what's on the formulary, you may use ACE or you may use the ARB. Giving them both together causes a lot of problem, mostly hyperkalemia, heart failure, a lot of other issues. So either you give them ACE or ARBs. Generally, ACE are preferred, but some people may develop cough, may have angioedema, some kind of a problem, then you have to switch them to ARBs. If they have angioedema with ACE inhibitors, then don't give them ARBs. In pregnant women, we try not to give them ARBs either or ACE inhibitors. ACE inhibitors are strongly contraindicated in patients that are pregnant. Beta blockers can be used, but generally are not preferred, and now they've become a third or fourth line of drug. Calcium channel blockers have gone up high on the scale, and it's once a day. You can start with 2.5 milligram of amlodipine and gradually work your way up to 10 milligram daily. Usually with 2.5, there is not much problem, but with 5 milligram, I have seen more patients develop a pedal edema, and it seems to have some kind of a cyclical variation. Some people have it in the morning, some people have it in the evening, some may have it every other day, and usually adding a thiazide diuretics with that helps them get rid of the fluid or the pedal edema that they may have. In the end, here you can see the thiazide diuretics, and generally we try to give them hydrochlorothiazide. Start with 12.5 milligram. They can go to about 25 milligram if you want, and the highest dose that you give is 100 milligram. And again, as you can see, all of them are 1 to 2 times a day. So people that are fasting can take it. They can take it with iftar, and they can take it with sehri. These are the guideline-directed therapy required. Initial drug therapy with first two-line agents of different classes can be used in people that have more than 20 to 10 millimeters mercury above their blood pressure target. And usually we try to bring the blood pressure down to 130 or 80 if we can with dose titration. And if one drug doesn't work, you can go ahead and add a second one. And if you don't see an effect with one drug, for example, you started somebody on amlodipine 2.5 milligram and you have not seen the blood pressure drop by about 2 to 4 millimeters of mercury, we know it's not going to work. You could try increasing it to 5 milligram for a few more days, but it might be appropriate to switch them to some other brand of calcium channel blocker or another kind of diuretics and see if it will help them out. ACE inhibitors seem to have better effect on blood pressure in African American, as I've mentioned earlier. So patients, when they have been found to have hypertension, adjusting the blood pressure medication response can be done either in the clinic by a physician or by a nurse that come to the where they can get the blood pressure checked. And sometimes we have telehealth that can go ahead and look at the patient's blood pressure recording. Patient can transmit the blood pressure log to us, and that's looked at by either a pharmacist or by an RN, and then based on what they say the readings are, the blood pressure medication can be readjusted. It's important to know that the calcium channel blockers like amlodipine, one needs to wait at least for 4 days before you want to double the dose. Increasing the dose before 4 days can cause them to have a hypotension. It takes a little while longer to work. Lisinopril, you can see the effect within a day or so. So usually asking them to call every week with the blood pressure or with their readings of ambulatory blood pressure monitoring or home-based blood pressure monitoring is useful, and adjusting the medication accordingly would help us. With ACE inhibitors and diuretics, it's important to check their electrolytes, in a few days' time, just to make sure that they're not losing potassium or not accumulating too much of potassium. ACE inhibitors, watch out for hyperkalemia, and patients that are on diuretics, we watch out for hypokalemia. Once we start seeing hypokalemia, we have got to make sure that it's replenished. And generally, the magnesium also tend to be a little on the low side, so getting them magnesium with the potassium usually helps them. Some patients can be just educated about taking an additional banana or an orange to bring up their potassium is useful, and taking our dates also would help them with the potassium. So here is the blood pressure threshold and recommendation for treatment and follow-up. If a person has normal blood pressure, we have got to encourage optimal lifestyle habits, and these patients have to be reassessed yearly. In a person that has elevated blood pressure but not in the hypertensive range, they again have to be promoted to have a healthy lifestyle, and these patients have to be seen within 3 to 6 months because the chances of going into hypertension is relatively higher in a person that has elevated blood pressure than one that has a normal blood pressure. So generally, we recommend that they be seen in 3 months by one of the nurses or in 6 months by a physician so that the blood pressure can be checked again. Those that have stage 1 hypertension, we have to look at the atherosclerotic cardiovascular risk estimate. And if it's greater than 10%, then one could start doing the non-pharmacological therapy, like having them exercise, changing their dietary habits, eating a healthy diet in general, and helping them relax. That will help them bring down the blood pressure. But if the chances of having a cardiovascular risk is greater than 10% over 10 years, then we have got to add blood pressure medication in them. Those that have a stage 2, that means a systolic blood pressure greater than 140 over 90 millimeters of mercury, those need to have the blood pressure medication added on as soon as possible. All of them have to be reevaluated in 3 to 6 months. Some of them need to be reassessed in 1 month, especially those that are in hypertensive stage 2. One needs to check the blood pressure within 1 month and look at the goal, make sure it's met. If not, then we have to assess and optimize adherence to therapy. Generally, we'll find most patients are scared and will take the medicine for the first month or so. And then once you tell them that the blood pressure is better controlled, they tend to forget the medication more often. So compliance is a major issue. So having them talk to the nurse, have the nurse give them a follow-up call every few weeks to make sure that they're taking the medicine on time, or having them come in for an office visit will help them with the blood pressure management. Those that have ischemic heart disease, we need to have them on guideline-directed medical therapy. These people would need beta blocker, ACE inhibitors, or ARB, and look at the blood pressure. If the blood pressure goals are met, then that's fine. If not, then we for angina pectoris. If it's present, then we have to add dihydropyridine as needed. Those that in them they don't have any angina, you may think about adding a thiazide diuretics or any kind of mineralocorticoid inhibitors as needed. Those with kidney disease, again, for everybody, the blood pressure has to be less than 130 over 80. But those that have albuminuria, we worry about them more. They have to have an ACE inhibitor on board, unless they're intolerant to ACE inhibitor. If they're intolerant to ACE inhibitor, then we have to add ARBs. Otherwise, you can, if they don't have any kind of albuminuria, you can use any first-line medication choices. But albuminuria is most important. That means they have greater than 300 milligram per day of albumin in the urine. Those with kidney transplant, again, we have got to try and bring down the blood pressure less than 130 over 80. And it's reasonable to treat the patients with hypertension with a calcium antagonist on the basis to improve the GFR and kidney survival. Calcium channel blockers have been proven over time, and it's part of the routine in patients that have either transplant, whether kidney or cardiac, that we try to add calcium channel blocker. We try to find a reason why we should be adding a calcium channel blocker on those patients. Patients that present with acute intracranial hemorrhage, we have to bring down the blood pressure. And usually, if they have a systolic blood pressure 150 over 220, we try to bring down the blood pressure to less than 140 over millimeters mercury, but make it over a few days' time, not necessarily over 1 day. Those that have a systolic blood pressure greater than 220, you have to bring down the blood pressure at least by 20% or 20 degrees lower than what it was before, and monitor the blood pressure closely. Never try to bring down the blood pressure to normal level in a patient with intracranial hemorrhage within a few hours. It's important to make it a slow process. Similarly, somebody with an acute ischemic stroke, we have got to look at the systolic blood pressure. And if they have a systolic blood pressure which is well controlled, then they may qualify for thrombolytic therapy. Those that have a blood pressure greater than 185, we try not to give them thrombolytics, but we try to bring the blood pressure down to 180 or 105 for the first 24 hours after they get the thrombolytic therapy. Sometimes after the thrombolytic therapy, the blood pressure may normalize on their own. And if the patient's blood pressure is too high, then they do not get any kind of thrombolytic therapy. That means somebody that's greater than 220 or 110 or any kind. We'd lower down the blood pressure by 15% in the first 24 hours by only 15%. Similarly, those with a previous history of stroke for secondary prevention that come in with having had a stroke a couple of days earlier or more than 72 hours, we look at their history of hypertension. If they have a history of hypertension, we restart the antihypertensive treatment. Aim is to bring down the blood pressure to less than 140/90. And those that have established blood pressure greater than 140/90, then we treat them with antihypertensive with the goal to bring down the blood pressure to 130/80. Again, making sure that it doesn't come down immediately, but just wait for a few days for it to come down. Those that have established blood pressure which is less than 140/90, it is useful to start about antihypertensive therapy, but it's not really known. Bringing down the blood pressure at that time will help them. So we may want to wait for a couple of weeks, couple of months before we go ahead and start them on antihypertensive therapy. Those that are having an hypertensive crisis, we look at the target organ damage, making sure it's not getting worse, progressing. If not, then we just go ahead and reinstitute and intensify their oral antihypertensive drug and arrange for follow-up. On the other hand, if they have an hypertensive emergency, that means they have a target organ damage, we have to admit them to ICU. Condition that we always try to look out for is aortic dissection in these people, look for severe preeclampsia, eclampsia in pregnant women, and some people may have pheochromocytoma crisis. We have to try and reduce the blood pressure as much as we can, especially in a patient with aortic dissection. It's important to bring down the blood pressure real fast. In others, try to reduce the blood pressure by maximum of 25% over the first hour, then to gradually over time, over 48 hours. So here is the chart showing the sequence of management of patients with hypertension. If somebody sees a person in the clinic where they suspect the person has got hypertension, blood pressure may be measured by one of the medical assistants, and then the physician should also try and measure it again to make sure that they have at least two readings and say that the person is hypertensive, yes or no. We have got to try and detect white coat hypertension or masked hypertension in some patients, depending on the symptoms, what they come in with, either by using ambulatory blood pressure monitoring or home-based blood pressure monitoring. Sometimes we have to evaluate for secondary hypertension, as I mentioned, and look for a target organ damage which may have been present because of persistent hypertension they may have had for a long time. We have to introduce lifestyle intervention and discuss treatment goal. It's important to discuss lifestyle intervention, one intervention at every clinic visit. Treatment goals are important. We have to tell the patients why it's important to bring down the blood pressure and how much are you looking out for a blood pressure drop. Try not to give them too much of a blood pressure drop requirement initially. It will be a little shocking for the patient. If they have a blood pressure 160/90, tell them you would like to see them again within a couple of weeks and like to see it at 150/90. And if it's less than 10 millimeters of mercury, then you have to intensify the treatment. Otherwise, continue with the same treatment with lifestyle modification. See them again in a month or two before you readjust the medication. Appropriate follow-up is important, and always try to use a team-based care. Patients should take care of their blood pressure. Same thing about their family member. They can be a partner in their health care, take the blood pressure for them, and connect the patient to clinician by telehealth. Not necessarily present in all offices, but if you're associated with a big organization or big kind of a group, they would have telehealth for you, and there the nurses will be talking to the patient every few days, making sure the blood pressure appropriately recorded and sent out to them, and they will keep a flow sheet for the patient. Sometimes the patients can download their data down onto the flow sheet for the text to see and the nurses to see. That will help them detect and reverse non-adherence. Non-adherence to medical therapy is most important. Generally, if you see a spike in the blood pressure reading, it's important to ask them if they had taken something unusual, for example, gone out for dinner with their friends or family, or if they kept taking a medication for one reason or the other. Sometimes they forget because they had gone out to their friend's place and, they missed one night dose and they took it only in the morning, so the blood pressure will be a little bit higher in the morning. We have to learn to detect white coat effect as well as masked uncontrolled hypertension. And we have to use health information technology for remote monitoring and self-blood pressure monitoring. All of these are important. This is summary of blood pressure threshold and goals for blood pressure. Those that may have a clinical cardiovascular disease, a 10-year risk greater than 10%, it's important to bring it down to 130/90. Those that don't have any kind of risk, you can allow it to go up a little bit, but make sure bring it down to goal over time with dietary modification. In patients that are living in an institution, there's no point in trying to make the blood pressure control too hard because most of them would have orthostatic hypotension. Most of them are on other drugs that will lower the blood pressure and make them feel dizzy, and the vessels don't contract as easily as in a young person. Therefore, they need more blood pressure. There's some specific condition in which we all try to bring down the blood pressure, and as you can see, all of them require the blood pressure to say that the goal is less than 130/80. It doesn't matter whether you have diabetes, CKD, renal transplant, heart failure, ischemic heart disease. For everybody, the goal is less than 130/80, and you have to start treating them for their blood pressure depending on what are the condition that they have. So for treatment of hypertension, lifestyle changes are the most important one. They have to be used to lower blood pressure before starting drug therapy. However, if the blood pressure is too high, you have to start drug therapy in addition to lifestyle changes. And if the lifestyle changes make a remarkable change, say for example, you had somebody who was 260 pounds and now he's 180, you could start cutting down on their medication over time as the blood pressure starts under better control. Sodium intake should also be limited to less than 100 millimoles per day or 6 grams of sodium chloride. That means less than 1 teaspoon as shown above here. You can see what 1 teaspoon stands for and how much of sodium is there in 1 teaspoon or half a teaspoon. It's important to encourage our patients to take a diet which is rich in potassium, low in sodium, and it's important that they should have regular aerobic physical activity. Brisk walking, greater than 30 minutes, no need for you to run, jump around, just brisk walking every day, that will help you. If you cannot do it in 30 minutes, just do 10 minutes in the morning, 10 minutes in the afternoon, 10 minutes at the evening. It doesn't matter how you do it, but 30 minutes is what is required for most of the days. 5 to 6 days a week is also enough if you can talk them into it. Alcohol consumption, it doesn't apply to our Muslim people, but if anybody is a drinker, no more than 3 units per day for men and no more than 2 units per day for women. Consume a diet that is rich in fruit and vegetables, at least 5 portions per day. These are some of the foods that help lower blood pressure. And most of us take it like leaf greeny vegetables, berries, red beets, skim milk and yogurt, oatmeal, bananas, salmon, any other kind of fish, seeds, garlics and herbs, dark chocolate, pistachio, olive oil, and pomegranates. These help lower the blood pressure. And these have been proven in a few studies that will lower the blood pressure. There was an NIH study that looked at skim milk and yogurt, and they found that if the person takes at least 3 servings of skim milk or yogurt per day, the blood pressure was lower than those that did not take it. Oatmeal similarly also helps with the blood pressure. Bananas have high in potassium, and that helps. Here is a little bit of a diagram about the DASH diet based on 2000 calories. And I was surprised that most of us don't really take 2000 calorie of diet. We take about 1500, and most of it should be grains, some vegetables, some fruits, and that's what we need to live on. Serving sizes are listed here for you to look at, and what the serving size will bring as time goes along. This is taken up from the NIH website and also from the NHLBI website, indicating that you should have a higher amount of vegetables and healthy proteins, some whole grain and fruits. Drink as much water as you like and use healthy oils. So in end, track what you eat, avoid sodium as much as you can, know what you eat, and if you keep a diary, you will be able to tell what you're eating. Look at dietary approaches to stop hypertension, which is also called DASH. That means eating stuff that is rich in fruits, vegetables, whole grains, fish, poultry, nuts and legumes, and low-fat diet. And importantly, get started with exercise. Find a buddy, somebody that can help you lose weight, lose extra pound, watch your waistline, exercise regularly, and get support from somebody at home as well as a doctor and see them regularly. I thank you for your attention.
Jazakallah khair, Dr. Moten. Thank you so much for the comprehensive overview on hypertension. We have about 5 more minutes. If anyone has any questions, you can type them in, or you can speak if you unmute your mic. While we're waiting, I do have one quick question, which is, do you have any tips or advice for those patients who are hoping to fast during Ramadan but have high blood pressure and take medication for it?
Yeah, as I mentioned, most of the hypertensive medication that you would like to give are twice a day. Whether you give them diuretics, whether you're giving them calcium channel blocker, whether you're giving them ACE inhibitors, and those are the preferred drugs. So that some calcium channel blockers, for example, amlodipine, which can be given only once a day. If for any reason somebody's doctor has put down something that's 3 times a day, you could talk to them and have it switched over to once a day or twice a day drug. Even calcium channel blockers like diltiazem, or if you're looking at verapamil, they all come in long-acting formulary, which are all on a tier 1 drug, not tier 2 or tier 3 drugs. That means they are covered by most of the formularies, and you can use those. Same thing about diuretics. You take the diuretics in the morning when you're going to be, when you have your sehri, take it at that time. So you're home, and at that time, if you have to go to the bathroom a few times, it's not going to hurt you. And that will help lower your blood pressure. Relaxation is very important. And when you pray, if you take your time in praying, reciting the Quran, saying your prayers, not in a hurry, that will lower your blood pressure to quite an extent. It has been proven, like for example, any kind of meditation helps lower the blood pressure. So if you were to look at our habits as Muslims, for example, meditation, we all like to recite Quran during Ramadan. We want to go ahead and say our prayers on time. Sometimes we're in a hurry, but if we slow down, take our time, recite properly, then we should do well. Medications are important, but if medications are required only 1 to 2 times a day for hypertension. So, you take 1 dose at iftar and you take the second dose at sehri. That's more than enough, whether you're living in the northeast or whether you're living on the south. You at least have 8 or 10 hours of non-fasting time. So you take 1 drug in the say iftar, and the other one you take it sehri. Even if you take them 6 hours apart, that's fine. That's not a problem. So I hope that will help a lot of individuals.
Inshallah. Jazakallah khair, Dr. Moten. I want to thank Dr. Moten for taking her time and effort to put together this presentation for us today. And I want to thank everyone who was able to tune in tonight, and for those who in the future will be listening to this recording. This was hosted by the IMANA Education Committee, and we hope, inshallah, to have some more webinars that will provide some preventive health education to our community. And without further ado, we'll go ahead and close the webinar for the evening. And just again, Jazakallah khair to Dr. Moten and for all those who have listened in. Assalamu alaikum wa rahmatullahi wa barakatuh.